Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week it's a conversation about lung cancer with Dr. Roy Herbst. Dr. Herbst is the Ensign Professor of Medicine and Medical Oncology and Professor of Pharmacology at the Yale School of Medicine. Here's Dr. Weiner.
I like to just start off hearing a little bit about what brought somebody to a career in cancer medicine and cancer research. And maybe you could spend just a minute or so telling us about what motivated you when you were in medical school or even before medical school to go into this area.
Well, my mother always wanted me to be a doctor, and she brought me up here to Yale quite a few years ago. And I was very interested in science, and I liked working with people. So when I got to Yale as an undergraduate, I studied molecular biophysics and biochemistry in the lab in the clinic, and knew that I wanted to go for a career in medicine. But it really, my career in oncology really began when I was an MD PhD student in New York City at Cornell and Rockefeller universities. And, I was working in a lab studying gene expression, and my mother developed breast cancer at that time. I don't think I've ever told you this. And this is, in the late 80s. And I sought opinions at my hospital and elsewhere. I went and reviewed her pathology. And I just became fascinated, in oncology and some of the new therapies that were available at that time and the research that was going on. So I knew I wanted to work in cancer, not lung cancer. I can tell you how that happened, but I knew I wanted to be an oncologist. And from then on, my training was focused in that way.
Well, perhaps not so good for women with breast cancer, but very good for people with lung cancer. You became a lung cancer specialist. And maybe you can just tell us a little bit about what lung cancer was like back when you first were a young lung cancer doctor.
I always wanted to train in Boston, so I did my residency and fellowship in Boston, and I was at Dana-Farber Cancer Institute. And in those days, actually, everyone wanted to work in the area of breast cancer or leukemia and lymphoma. HER2 had just been sort of described, and all the different drugs and markers in leukemia and lymphoma. But there was a job available in lung cancer. And I actually had two wonderful mentors, Tom Fry, actually a Yale graduate, one of the founders of oncology. He was in his later years, and Arthur Scarin, and they encouraged me to work in the lung cancer clinic. And back then, I must tell you, the reason that job was available is because there really wasn't much we could offer in lung cancer. If someone came in and the lung cancer had already spread, we had some chemotherapies that were moderately effective, and that's being generous. There was no gene therapy, targeted therapy, immune therapy, and it really was a tough time. But I was struck by the science and the fact that there was a good deal of research going on in growth factor receptors. So I specialized in lung cancer for a year. And I did an extra year as an instructor up at Harvard. And I also took a course and a program in clinical investigation, a master's program there. Actually, ironically, I now lead a master's program here at Yale in a very similar way. And during that time, I really became fascinated by lung cancer. I learned all I could about that, so that when I got my first job at MD Anderson Cancer Center in Texas, I was ready to roll with an amazing dynamic group that was just beginning to study epidermal growth factor and some of the new targeted therapies in the disease. So it was a tough time, but as we'll talk about, there's been amazing progress now in the last 20, 30 years.
And before we get to lung cancer treatment, maybe you could say a few words about what causes lung cancer. I think many people know that tobacco is a huge carcinogen, but maybe you could quantify that and tell us just how many people develop lung cancer each year and how much of that is related to tobacco use.
Well, that's changed during the course of my 30-year career. So when I started seeing patients with lung cancer, and this was an era before we had electronic films, people would come, from Maine or from Connecticut or from wherever they came to Boston, and they'd bring a packet of X-ray films, and you'd often be able to smell the smoke on those films because it was a disease. where most people were smokers. About 80% of people smoke, and smoking still is the number one cause of lung cancer. But, since the last 25 years, we now know that there are people who have not smoked or have smoked very little that get lung cancer too. And interestingly, it's a very different type of lung cancer that we treat in very specific ways. Other causes of lung cancer would be radon gas, something many of us have to think about, especially if you have a basement here in Connecticut. I know I have a little detector down there. I'm not sure it works, but I got one. And then, of course, asbestos, another thing we have to worry about in some of the old homes here. So, and then, of course, pollution and where you live. But really, what we now do is, whether you're a smoker or non-smoker, we have treatments for the lung cancer, but they are different.
And if somebody smoked in the past and they've stopped smoking, does their risk for lung cancer go down? Does it persist?
Oh, it goes down. And that's why, I was very fortunate. So I went to work in Houston with a fellow named Juan Quijano, who is very focused on chemo prevention and smoking cessation. And he used to talk about those good citizens, the people that would stop smoking and how we could, get them to stop smoking. And yes, if you stop smoking after 20, 30 years, your risk does come back down, but it takes a long time. And it's never quite back to the baseline. But certainly the most important thing is smoking cessation. And we've done a lot of work with that, with AACR, with ASCO, the other organizations, the societies. Here at Yale, we have a major smoking cessation program. So that's the best way to deal with lung cancer, to never get it and to not smoke. So that's something that we've really focused on, and it does reduce the risk.
And if lung cancer is caught really early, that's a time when surgeons get involved as well.
Oh yeah, and that's one of the things that always attracted me to working in this field. It's a true multimodality field where the medical oncologists like myself, we give chemotherapy, immunotherapy, targeted therapy, work with the surgeons and even radiation oncologists, and then of course all the science that's involved in identifying what type of lung cancer there is. But yes, early lung cancer can be treated with surgery. That means you have to find it early. The problem with lung cancer is more than 50% of the time at diagnosis, it's already spread to the liver, the bone, the other lung, dare I say the brain. So there are a lot of concerns there. So we have to find it early. So I guess, the thing that, we're doing now is screening. Screening has become a major force in this field. And of course, many of the hospitals do it. We do it here at Yale. And it's very important to find it early, because if you find it early, not only can you cut it out and hopefully get it all out, there's still a risk of recurrence, but we have other therapies that we can now do in a personalized way to reduce that as well. So early detection is clearly the key to treating lung cancer, as it is, of course, with almost every cancer.
Well, we'll get back to screening a little bit later, because I think one of the unfortunate things is that not everyone gets screening who should get screening. But are there patients now who have early enough lung cancer that they just get surgery?
Yeah. Lung cancer is stages 1, 2, 3, and 4. I don't need to go through all the details, but let's say you have a stage 1 lung cancer. That's commonly found. You're going in for a hernia repair or some other procedure. You get a chest x-ray. You're found that you have a small nodule in the lung. Maybe it's a centimeter or 2. Those would be stage 1 disease, assuming there's no spread locally to lymph nodes. That has about an 80-90% chance of cure. Those patients might just have surgery alone, and then we'll follow them on a every 6-month or yearly basis. The problem is oftentimes we'll find some evidence of spread, maybe a local lymph node, one of the way stations where the cancer cells might deposit, or we might find that the cancer's gone to a lymph node on the other side of the lung. And then we have to sort of evoke, the full multimodality approach, bring in chemotherapy and radiation therapy. But now, of course, we would profile the tumor and we would try to understand, can we treat it with one of these new targeted agents, which are more commonly used in people who have smoked very little.
And when you say profiling the tumor, what exactly do you mean by that?
Well, it's really not lung cancer, it's lung cancers. Everyone's cancer is a little different. And, the engine that's causing that tumor to grow is different. There might be an abnormality in one piece of DNA versus another. So nowadays in 2025, We didn't know this in 1997 when I started this, but in 2025, we can actually take the tumor, we get a biopsy, we send it off to the lab. It takes about a week, maybe a week and a half or two, and we actually can look at a whole series of genetic alterations that we know can cause this lung cancer. And then it really is a personalized treatment we can give the patient because it's the right treatment for the right abnormality at the right time. And, that includes, mutations in a gene, for example, that's called epidermal growth factor receptor. We actually just celebrated 20 years last year of the discovery of the mutation, which has truly changed the way we treat this disease. Because if someone has that abnormality and we find it in the advanced state, we can use an oral drug and prolong their life. Or in the early stage, we can even use that drug to potentially even cure their cancer. So it's really important that we know exactly what type of lung cancer someone has. Now, someone who might have smoked a lot or had smoked in the past and stopped and doesn't have any of these actionable, what we call mutations, still has a great chance at good therapy now because they're someone we might use immunotherapy for.
And we'll get to immunotherapy because you've done a lot of work in that area in just a few minutes or maybe in the second half of this show. But so EGFR, which was the first of these genetic changes that was identified, is present in what percentage of patients with lung cancer in the United States? Because it's different in different countries around the world.
Oh, absolutely. In the United States, it's about 10 to 15% of lung cancers, which if you think of lung cancer, which is still the number one cause of cancer death, being 250,000 patients a year in the United States, that's a lot of patients. So we look for it. And there are about 9 other similar alterations. I won't go through every one in detail today, but that if we know about it, we can try to pair a patient with a specific drug. But by the way, if you go to China or Japan, Vietnam, the rates can be as high as 30% or more. So there's something about East Asia. We're still trying to figure that out where it's much more common.
And those other 9 or the other 8, in total, are they similar to EGFR?
No, well, they're similar in that the majority of them, we see the same response, meaning we can give the pill and the patient benefits, but they're much less frequent. The next one down from EGFR is something called ALK, and then a little bit less than that, ROS1. But then we're getting into 1 to 2%. Now,
and ALK is like 4%?
3 or 4%. And aggregate, they all get to about 20%. Now, this is important. Even if it's only 1% of 250,000 patients a year, and worldwide, 2 million patients a year is still a lot. But we have to find it. And I'll leave you this. We have to find it in all patients. No matter where you live, who you are, if we don't get the cancer biopsy and send it to the lab, we'll never have these options. So the most important thing I can leave you with tonight is we really need to find a way to screen all patients so that we know who has these abnormalities so we can treat them in more specific ways. And that's a big part of our research here at Yale, as you know.
And there's still plenty of patients in the United States alone who don't get this kind of detailed evaluation of their lung cancers.
Yeah, better than it used to be because people know to refer patients with lung cancer. But there are many patients who might never get a biopsy, may never get it profiled. I'd say there are 15, 20% still that don't have that. And it's really important to know that because this is how we treat in the most aggressive way. Now, it might be that someone's so sick they never get the biopsy, but this is why finding it early, getting the biopsy, and then using that information to treat, that's what really raises the bar and improves care for all patients.
Well, thanks. Well, we're going to take just a very brief break, and we will be back in a minute and spend some additional time with Dr. Roy Herbst, who is the Ensign Professor of Medicine at Yale School of Medicine.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their hematology program offers comprehensive diagnosis and treatment of blood cancers, including lymphoma, leukemia, and myeloma. SmiloCancerHospital.org. There are over 16.9 million cancer survivors in the U.S. and over 240,000 here in Connecticut. Completing treatment for cancer is a very exciting milestone, but cancer and its treatment can be a life-changing experience. The return to normal activities and relationships may be difficult, and cancer survivors may face other long-term side effects of cancer, including heart problems, osteoporosis, fertility issues, and an increased risk of second cancers. Resources for cancer survivors are available at federally designated comprehensive cancer centers, such as the Yale Cancer Center and its Milo Cancer Hospital, to keep cancer survivors well and focused on healthy living. The Milo Cancer Hospital Survivorship Clinic focuses on providing guidance and direction to empower survivors to take steps to maximize their health, quality of life, and longevity. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Eric Weiner here with Yale Cancer Answers, and we're going to be speaking with Roy Herbst, who is the Ensign Professor of Medicine, Deputy Dean of the Yale Cancer Center. We're talking about lung cancer, and we're talking about lung cancer treatment. So we were just talking about some of the genetic changes that lead to targeted therapies for lung cancer, talking about the fact that it's really important to sort out which genetic changes are present in which patients. And Roy, without this, you're really functioning in the dark if you don't have that kind of profiling.
Oh, absolutely. We like to say science drives the best care. So by really, it's like if you brought your car in, you'd want to know what was wrong with the engine and fix it in the right way. So that's what we're doing here. But I just want to say one thing, Eric. As good as these targeted therapies are, and I was very fortunate to be one of the first to use these when I was in Houston, 25 plus years ago. Very rarely does someone go forever on these drugs. Tumors, unfortunately, are evil. They learn how to become resistant. So we're constantly looking for ways to overcome that resistance. And I'll just say that's a big part of our research, and that's why clinical trials are so important, because we're always trying to do a little bit better. So nowadays, we have clinical trials, and they're available throughout the country, around the world, but we need clinical trials to try to understand how to even do better. So that's part of the goal of research in lung cancer these days.
No, it's true. Even sometimes the dumbest tumors are smarter than the smartest oncologists. And, that means that they figure out ways to get around the treatments that we put in their way. Although increasingly we're more and more successful than we were at one time.
Absolutely.
So chemotherapy used to be the backbone of the treatment, or the main treatment. Now it's sort of playing a secondary role. We still use it, but we think about these other treatments. Maybe we can turn now and talk about immunotherapy. You've been very involved in immunotherapy clinical trials over the years, and lung cancer is one of those diseases, or at least some lung cancers, where immunotherapy has had a huge benefit.
Oh, it's incredible. Well, it's actually funny. You talk about the evolution of a career. So I was leading the lung cancer group at MD Anderson for many years and did a lot of the early work with targeted therapy. But I really first learned about immunotherapy here at Yale. I'm here 14 years now. And when I came here, Yale, maybe Johns Hopkins, those were the places people were coming back in 2010, 2011 for a drug known as nivolumab, the first inhibitor of a checkpoint called PD-1. And basically the idea is that you have a tumor and you would think that the immune system would eliminate that tumor. And it should, because the tumor is a foreign body in the blood. But the tumor has a force field that keeps that immune cell away. And these drugs actually, attack and overcome that resistance. And the first early trials were done here. And I remember when I first arrived, I was very fortunate. Mario Snow, Scott Gettinger, Harriet Kluger, Li-Ping Chen, one of the discoverers of PD-L1 had just arrived. We had a nucleus of people, and it's just been wonderful, running trials and doing laboratory research to really try to help patients with lung cancer, melanoma, renal cancer, many cancers. But lung cancer is one of the cancers where immune therapy really does have an impact. And, I would say that we can cure people with lung cancer with immunotherapy. The problem is it's only about 10%. So we're constantly trying to do better, but many more patients do benefit. And if we can figure out how to even do better, I think it'll be tremendous.
You know, I often say that what makes cancer so challenging is that it is both a foreign body, but it's also a foreign body that came from us. We gave birth to it. It arose in us. And maybe that's part of the reason why cancer's figured out how to make these substances that tell the immune system to just stay away.
Right. If we don't regulate the immune system, think about getting poison ivy. That's an immune reaction. Imagine if the immune system went wild against normal organs. It does. Those are what we call autoimmune diseases, thyroiditis and lupus and other things. So the body is it's fantastic how things present to the immune system in the context of self, but there has to be a way to regulate it. So it is amazing to think about the evolution of this.
Yeah, and of course, we want the immune system to attack the cancer like crazy, but we don't want the immune system to start attacking us.
Right. And you think about it, the immune system, what could be more specific? What could be more adaptive? And then the key thing about the immune system is memory. So it's just like we give a vaccine. We want a specific and an adaptive and a memory response. We can get that in cancer. And I'll tell you, some of the early experiences I had with immunotherapy here, working with our team, we were very fortunate because one of the things we were able to do is we were able to get biopsies on patients who were getting these drugs because, we want to see these drugs work, but to understand how they'll work for more patients, we want to understand why they work in some and not others. And by doing some of this work as part of our SPORE, our Specialized Program of Research Excellence in Lung Cancer here, we actually have learned, what are some of the markers that tell you who might benefit more or less. And over the years, immune therapy is really a staple for most patients with lung cancer. But interestingly, in the smokers, not the never smokers, so the people that have never smoked tend to have these other mutations. They actually don't do as well with immune therapy. It's ironic and it's not fair. It's because their tumor is being run by these one or two mutations that they got genetically, but there aren't enough abnormalities to stimulate the immune system as in someone who might have smoked a lot. Don't anyone go out and start smoking. It's not going to help you with your lung cancer treatment. But it is really dichotomized lung cancer treatment into different ways. And we're actually working now to figure out how to use immune approaches for people who have never smoked as well. But I'll tell you, I've seen people, thinking back to my days in the Dana-Farber, who back then would have gotten chemotherapy with many side effects and would have lived just a very short period of time. People that are coming back 3, 4, 5 years later. It really has made lung cancer, for me as someone who comes in every day excited to see patients and do research, something where I can feel that progress myself during my own career.
And to what extent have lung cancer deaths gone down? And some of it is about the decline in smoking, and some of it is about more effective therapy. But it has really had a tangible effect.
Yeah, these data that come from like the American Cancer Society tend to lag by about 4 or 5 years. The last big cut of data we had showed incidence decreasing by 2-3% a year and mortality going down by about 3 to 5% a year. So it's not just not smoking and better public health, but it's also it is the drugs. And what we've seen in the past is probably just the targeted therapy approach. I think the immune therapy numbers we'll probably see in the next year or two, because really immunotherapy only became standard of care in this country. It's barely 10 years. But yeah, it really has changed the way we think of this disease. And it's important, therefore, that one really understand what type of cancer they have and what multimodality therapies they need. One thing I want to bring up is we now know that if we use the immunotherapy in the earliest stages of disease, not when someone comes in with the lung cancer already having spread, and if that happens, we can deal with it. But if we find the lung cancer when it's still localized in the lung or perhaps to some lymph nodes in the lung, we can actually give the immunotherapy, sometimes with chemotherapy, before surgery. And, we have a tumor board here once a week, and it amazes me when the surgeons tell us what they've seen. They go into one of these patients after they've had this chemotherapy, immunotherapy, and the tumor's gone. Or if there is something there, when you look at it in the pathology lab, all the cancer cells are dead. So it really is a very powerful treatment that you can use before surgery to really kill that tumor and make for a much better result. So this is why multimodality therapy, knowing what you're dealing with, the right treatment at the right time, it makes a difference.
No, I think that lung cancer is just, one of the most prominent examples of how cancer therapeutics have just changed and been revolutionized over the past 10, 15, 20 years.
But we're not done. And that's the thing, it's not always apparent to people, because, you come in with that cancer, you want to find the best therapy. So again, I'm going to say it. This is why the clinical trials that we were running here at Yale in 2011 are now the standard of care, immunotherapy. And you could only get immunotherapy from 2011 to 2015 on a clinical trial. So that's why, you and I both know it's important to ask good questions and continue to add new drugs or understand mechanism of cancer growth better so that we can be even more effective.
Yeah, no, and I think people need to understand that although progress has been made, we still have a lot of work to do, and this is the time not to put on the brakes, but to step hard on the accelerator of cancer research, because that's how we're going to really change the field even further in the next 2 decades.
Well, I've been telling our students and fellows, cancer's not a political disease. It's not Republican or Democrat. It's personal. Everyone can be touched by cancer, so we have to put all of our efforts to fight this disease in the most aggressive way.
So let's circle back to lung cancer screening. We've known for a number of years that for people who have smoked and are at higher than usual risk, that screening really makes a difference. But pretty few people get screening. It's not like mammography. It's not even like colonoscopy or other techniques that we use to screen for colon cancer. Only the smallest minority of people get lung cancer screening. Tell us about that and why you think that more people don't get screening.
Right. Well, first of all, the data are quite clear, both from U.S. as well as international databases, that if you find cancer early, especially now with all the new treatments we're talking about, we can make a difference. And right now in the U.S., most recommendations would say people ages 50 to 80 years old who have smoked at least 20 pack years, meaning 1 pack a day for 20 years or 2 packs a day for 10 years, and they're either a current or a former smoker within 15 years should get screened. You can make a case that you should expand that, but let's just focus on this group. And why are only 5 to 7% or so of eligible patients getting screened? A lot of reasons. As opposed to colon cancer screening, which everyone should have, or breast cancer screening, which we would recommend. Lung cancer screening, when you find something, it's not as easy to go in and do a sampling. In colonoscopy, usually you wake up and they tell you, well, we found something, we've taken it out, we've made the determination. With breast cancer biopsies, I'm talking to you, you know better than me, but in my experience, you can do a biopsy sometimes right in the clinic that day, even do an ultrasound and do the biopsy. But with lung cancer, it's a little bit more complicated. I also think that we need to spread the word more, and that's important. Until recently, it wasn't fully reimbursed, but many insurance now and Medicare does reimburse it. We need to do more screening, because if we screen patients and found the lung cancer early, we'd have more impact on this disease than all the therapies we've talked about during the last 20, 30 minutes.
Dr. Roy Herbst is the Ensign Professor of Medicine and Medical Oncology and Professor of Pharmacology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.